Hi folks, during my last video I said the spring is here and the birds are chirping, and here we are now in Boston into April, and here it is, the background to my little backdrop here. As you can see, there's a snowstorm going on right here in the middle of spring in the Boston Common. And you know, these kinds of things are not unexpected in the New England weather that we always have. It's always unpredictable. However, I'm heading out to San Francisco tonight for the American Association of Endodontists meeting. So I'm getting out of here and I'm looking forward to that. It's also promising to be a pretty nice meeting. So I'm going to ask you guys to come along with me as we kind of do a little bit of a vlog of kind of capturing the experience of being at the AAE in San Francisco. So let's go and see what's happening in San Francisco.
Time is moving fast, reviewing all the lessons we have learned from mistakes lost in the past. Miscommunication leading us into a place where their lives strive. Why do we still tolerate the things like greed and hate that rule this life? When we can change the world, we can change the world. We can change the scores within a single generation, standing up for freedom, spreading hope nation to nation.
Hello, welcome nations. I'm joined here with Dr. Jerry Cymerman. We're in San Francisco for the last leg of our trip at the AAE 2016. And Jerry, first of all, thanks so much for joining me.
Oh, it's great to be here. A great meeting.
Jerry, the meeting has been really fabulous. Lots of great material, lots of educational things, and I think we've all really benefited from it. And I saw you and you had a couple of cases you wanted to share with our audience. So without further ado, we have a beautiful background of the Golden Gate Bridge. So why don't we quickly share these cases with our audience and make room for other people who want to take pictures right in front of this monument here. Terrific. So, okay, the first case here, Jerry, why don't you walk us through it?
Sure. You know, the patient was referred to my office to see if we could save this tooth. They had a prior root canal done a year ago. They were having pain and swelling. And the tricky thing about the tooth is it's right next to an implant, so we were kind of concerned about doing surgery. So we were going to, you know, attempt to retreat the tooth and save the tooth. So we took periapical x-rays.
Yeah. Right from the x-ray, Jerry, you can tell there is a missing, you know, obviously the root canal filling is a little bit off to the side, indicating that there's most likely an additional canal that was missed, correct?
Yeah.
Is that what your feeling was?
Yeah, that was our suspicion. So in a case like that, we usually try to find the canal and retreat the case as opposed to doing a surgical procedure.
Of course, that makes a lot of sense. So in order to find out what's going on, you took a CBCT here. And you can see here from one of the angles that there is the lesion, the periapical lesion is very close to the implant, with the chance that it could potentially cause problems for the implant as well, right?
Correct. And, you know, you have to be very concerned about an infection next to an implant. You want to be very careful prior to doing the implant to make sure there's no non-vital teeth adjacent to it. In this case, it happened afterwards. So we took the CBCT, and the reason there was difficulty in doing the root canal, on the axial view of the CBCT, you could see that the tooth was rotated, so it was difficult doing your standard access and finding that second canal. So actually, from what you told me, Jerry, somebody else already tried to go in there and they couldn't find the canal, right? Right.
And here in this x-ray, you went in there and you obviously found it. What do you think you did differently?
Well, we had the CBCT, so we knew exactly where to look for the canal, and we determined that the tooth was rotated. And if you do your standard access, as you can see, you don't really have direct access to the canal. So we had to alter our access a little bit to find the, the palatal root.
Yeah. So this is fairly common when you get a prosthesis on top of a tooth. Oftentimes it's trying to correct some kind of a orthodontic, whether rotation or tilting or something like that. and you end up having a lab-made crown that has been made to the ideal shape of the tooth. However, the root might be in a whole different configuration, orientation,
Right.
and that's what causes the problem for access preparation, whether it's for the first time doing the root canal or for doing a retreatment. In this case, the challenge of finding the additional canal. And where you did the CBCT here, I think that was really a key part, using that axial section to reorient yourself properly, right?
Right, exactly. And in a lot of these cases now with crowns on teeth where we suspect the tooth might be rotated or tilted, we're doing CBCTs to help us locate these canals.
So if somebody doesn't have a CBCT, do you have any tricks?
I would, typically what I would do with a crown, I would take a periodontal probe and I would go around the tooth, and you can feel the CEJ, and you can get a sense of whether or not the tooth is rotated or tilted, and that would be very helpful as well.
So using your DG16 Explorer or a perio probe, you can do root sounding, if you will, right?
Exactly.
You sound the root, so you actually get a three-dimensional configuration of the root at the level below the crown, because the crown is obstructing your real anatomy, but the root itself obviously is going to be what it is.
Exactly.
So you can always do that. You could probably put a kind of a maybe tape or glue a little instrument to the side of the crown and take an X-ray to just see how the crown is. Take a radiograph and see how it's orienting yourself. So you went in there and you did a beautiful job. So your post-op X-ray, you found the missing root canal and you instrumented it to the end. And you, what do you think? What do you have to say to the final?
I think this tooth has a good prognosis now. This case was just done a couple of months ago, and the patient's been asymptomatic, and we're going to bring him back for a 6-month recall to make sure the lesion heals
to see
up.
that lesion filling up.
Yes.
That's wonderful. So Jerry, let's quickly move on to the second case here. This is a case where you have restorations here in the anterior area. There's a little bit of marginal gingivitis due to some ill-fitting crowns and so on. And tooth 7, 8, and 9 seem to have radiographic problems with previous root canals, posts, and crowns, and periapical lesions, correct?
Yes, and the posts were very deep in this case, and the patient didn't want to redo the crowns for now, so we were attempting to retain these teeth, so we decided to do periapical surgery.
Okay, so the main reason, obviously the main goal of all treatment always is to eradicate the infection from the entire root, so a non-surgical retreatment usually, and disassembly is always our ideal treatment plan. In this particular case, however, given the fact that the patient had at the present time, from what I explained, what I was told, some financial difficulty, you guys decided to go with this compromise alternative treatment plan of doing the surgery first and then having the patient replace the crowns as soon as possible.
Yeah, and we were also concerned about the depth of the posts and trying to remove them and possibly creating a fracture in this situation.
Yeah.
So we analyzed it further by taking a CBCT, and this was tooth number 7. And the beauty of the CBCT before doing a surgery is you can actually map out where the lesion is. You take measurements from the incisal edge to the apex, so you know how long the tooth is, and you can take measurements from the buccal into the lesion, and you can pretty much pinpoint where the lesion is in this case. So on tooth number 7, we measured the root, and we did it for each of these three teeth.
For number 8 now.
Number 8.
And you can see the lesions present in number 9 here. It's a little bit on the lingual side.
Right, so we were concerned about a fracture in that case, and there was a horizontal root fracture at the coronal extent of that lesion. So that, we knew that ahead of time before doing the surgery. Yeah. So we knew when we went in there to do the surgery that we would have to remove that part of the root.
Yeah. So terrific. So this is very helpful. There's a little bit of beam hardening of the radiographs in this particular angle. So the spaces that you see around the post isn't necessarily due to any kind of leakage or problems. It's contrast by the X-ray. So this is your post-op radiograph showing that you've done a beautiful job. What technique did you use for your retrofilling here?
So we used the lid technique. We used a longer ultrasonic tip, and we filled the canals from the apical area with BC sealer, and then we capped that off with the BC putty.
With the putty right on top of it, and very quickly and efficiently. You got beautiful results here. Filled all the canals to up to the post almost, and that gives you a pretty good seal. And I hope that at some point this patient will go ahead and replace those crowns. And you have a 6 months follow-up too.
Right, and the bone was healing well. In this case, we also used calcium sulfate to prevent tissue ingrowth because there was some through-and-through lesions, and that was very helpful. And at 6 months, the bone was almost completely regenerated.
Terrific. Well, these two were really beautiful cases. Thank you so much for sharing us. There's lots of people here trying to take a picture
Yes,
in
they
front of the
were.
Golden Gate, and we're blocking their view before we have a revolt. Maybe we should call it a day here. And thank you so much for spending the time with me and sharing these cases with our audience. Very educational. It just goes to show that, with proper treatment planning and getting the fog, no pun intended, with the fog in the background,
Right.
out of your mind to concise and consolidate a treatment plan that you can communicate properly to the patient, so they know that they also have to replace these crowns at some point in the future.
Correct.
Soon. That's really important, because ultimately the goal is to get the best possible outcome in the long run for the patient and communicate these things properly. So again, the meeting was wonderful. I hope you had as much of a good time as I did.
Yeah, there's a lot of new information. It's always good to come to these meetings and see what's new and adjust how you do things in your practice.
Well, we're going to see you again next year, but I'm sure that we're going to see more of you on our website and sharing your information with our audience before next year.
Okay.
So, Dr. Jerry Cymerman, Program Director at the Stony Brook University in Long Island, New York, as well as in private practice in Long Island, New York. Thank you so much for joining me.
My pleasure. Thank you.
For Vivo Denda, I'm Ali Nassan. I hope you found this information helpful.